Hello, everyone. Good afternoon, ladies and gentlemen.
We get you loud and clear, Vitus.
Oh, great. It's good to have everyone, and welcome to Ultrasound Africa. Today, we have a special, one of its kind, and a rare opportunity to have some few discussants on a topic that is not known by so many of us who have done obstetric ultrasound, and that's fetal growth restriction. This is something that is not routinely done by so many of us. And maybe perhaps it's because we have one or two challenges. And hopefully from this webinar, we'll get to learn or we'll get to improve on how we can get to know, diagnose fetal growth restriction. With us, we have a panel of people. Two of them are experienced sonographers. They will be taking us through the challenges of diagnosing fetal growth restriction and how is growth restriction diagnosed. Then thereafter, we have a very experienced obstetrician who will give us how to go through this, the challenges of management of fetal growth restriction. So we'll have Julius Ojetri and Namwase Eunice, who are the sonographers who will be discussing for us this. And then we'll have a senior consultant obstetrician, Dr. Daniel Kakama, who will be discussing for us management of fetal. To start with is Eunice. Eunice is one of the young enterprising sonographers. She's working with Makerere University Hospital in one of the research projects. She's a student of Masters of Diagnostic Ultrasound. The colleague, Ojetri Julius, is also a sonographer who also works with the same institution, Makerere University Hospital. And Julius, just a month ago, he completed his master's in diagnostic ultrasound. The two of them are working in a very dedicated institution and department that has strict protocols, it being a research setting, and they have really interacted with fetal growth restriction quite extensively. Daniel, an experienced and consultant obstetrician, has managed very many of these. I think it will be in the best hands to discuss the management therein. So Eunice and Ojetri, if you are ready, you could share your slide and maybe, yeah, let's get started. Again, I want to emphasize, please look out in the chats. We'll be sharing the opinion polls. Please keep checking your chats. Julius, are you able to share your slide? Okay, great. So Julius and Eunice, the floor is yours. When you're ready, please unmute your microphone. If you also want, you can open up your cameras and get started.
Good evening. Good evening, good morning, good afternoon in your various locations. Vitus, are we clear? Are we audible from over here?
Yes, very audible.
Loud and clear.
Okay, thank you. So, yeah, once again, good morning, good afternoon, and good evening, colleagues, seniors, contemporaries, and everyone over here in your various locations. Presenting today about the role of ultrasound in fetal growth restriction is myself, Julius Ojetre, and my colleague Eunice Namwase. Vitas has duly introduced us, so I think we'll go straight. My screen is visible to everyone. Is it? Vitas?
Yes, we can see it. We can see the screen.
Yes,
Yes.
it is visible.
Okay, yeah, just in case of internet glitches, you could inform us when our slides don't shift. So, we're going to start by defining our fetal growth restriction. So this is a pathological inhibition of fetal growth and failure of the fetus to attain its growth potential determined by the genetic makeup. So there's quite a couple of these definitions, and one would argue why I am not defining this by the centiles of ultrasound. This is a broader definition that would cover everything, and later we'll look at defining by ultrasound this phenomenon. So FGR occurs in up to 10% of pregnancies. Of course, different literature states different things, and I actually believe this percentage could actually be low because of the low rates of detection. So this figure is only as per what has been able to be documented. So about 10% of pregnancies are affected by FGR, and it's actually a leading cause of infant morbidity and mortality. Point to note is it's reported to be about 6 times higher in the underdeveloped and developing countries, of which I think for this, Africa becomes a victim and culprit. And about 20% of all infants are small for gestation age. Small for gestation age at birth in low-income countries, and yeah, it's important to also note that fetal growth restriction is not synonymous with small for gestation age. It's just some elements of small for gestation age that arc into fetal growth restriction, but fetal growth restriction is not small for gestation age. As we continue, we'll look at the differences in these. And then, of course, it's highly associated with high-risk pregnancies. In one of the slides, we'll just outline some elements of high-risk pregnancies. So regarding etiology of fetal growth restriction, causes can be fetal, they can be maternal, they can be placental, and as well actually environmental. That's just not stated here. And most importantly, for the non-placental causes, they could be structural and chromosomal genetic anomalies like the trisomies 13 and 18, could have genetic conditions such as this Russell-Silver syndrome, but a couple of other syndromes could be associated with this. This is just an example. We could have congenital infections, the rubella, the cytomegalovirus, toxoplasmosis, and all the other torch infections. And then inborn errors of metabolism could also predispose to FGR. Placental causes, which are the majority and of more importance, especially with regard to this presentation. These are the most common placental causes. They are due to medical conditions that can affect placenta function. For example, preeclampsia, chronic hypertension, gestational hypertension, maternal diabetes, maternal vascular diseases that could range from the likes of atherosclerosis if it significantly affects the iliac vessels, thrombophilia, autoimmune diseases, hypoxemia secondary to cardiac cardiac disease, and then respiratory and hematological disorders. So again, with emphasis to placenta causes, which are the most common, these can be divided into three. The most common pathologies, maternal vascular malperfusion, inflammatory lesions, or velitis of unknown etiology, and then fetal vascular malperfusion. But of these, the best known lesion is maternal vascular malperfusion, which originates in early pregnancy due to deficient remodeling of the uterine spiral arteries by incomplete trophoblast invasion of spiral arteries, which would in effect leave the smooth muscle layer that is responsible for that constricted state of those arteries untampered with, and this would in effect result in high velocity maternal blood flow entering the intervillous space of the placenta and entering it into the and entering it too early in pregnancy. So we could have an early pregnancy being already affected by these high velocities and low resistance of the poorly remodeled spiral arteries. And the consequence is that it results in uneven and intermittent perfusion and development of the placenta. And consequently, where everything really becomes symptomatic, especially to the fetus, is the hypoxia, reoxygenation, damage, and activated immunological pathways that eventually cause the underperfusion. So other causes of placental and umbilical cord origin could be, for example, placental anomalies. Studies have shown how bilobate and circumvallate placenta, small placenta, and placental mesenchymal dysplasia, as well as some placental masses like chorioangioma, which is a lesion of vascular origin, how all these are associated with growth restriction. Umbilical cord anomalies have also been shown to be associated, like a single umbilical artery. Velamentous or marginal cord insertion is also also associated with FGR. So maternal risk factors associated with FGR, and some of them are associated with SGA as well. We're stating this because we realize in our society you're going to have walk-in patients. Not everyone works in a hospital setting. So these are very, very crucial to note. For our walk-in patients, it could be history that would be relevant to take. So maternal age of 35 or greater years, particularly the risk increases in women with that are above 40 years. African American or Indian Asian ethnicity, nulliparity, social deprivation. We know what this comes with quite a number of health related consequences. So these are in effect create a cascade of events, for example, housing, place of residence. These could all be predisposed to by reason of social deprivation. Body mass index of less than 20 or greater than 25. Alcohol intake and drug use, the likes of cocaine, heroin, and a number of them. Cigarette smoking, and then singleton pregnancies or assisted, we could summarize this as assisted conception. So singleton pregnancies following in vitro fertilization are also at risk for fetal growth restriction. Twin pregnancies as well have a high incidence, but I need to make a disclaimer at this point that we're not going to discuss twin pregnancies. This presentation is limited to singleton pregnancies. So just a bit of pathology of what happens, for example, when you have maternal vascular malperfusion. What are the consequences on the fetus? How does this fetus end up becoming small as a consequence? So body fat and muscle mass are reduced in the fetus, resulting in a decreased subcutaneous fat as well as body nitrogen and protein contents. And this reduction of maternal fetal transfer of nutrients due to placental insufficiency. Among the nutrients, glucose, amino acids, minerals, and the likes leads to lesser deposition of glycogen in the liver and muscles and minerals in the bones. As we all know, abdominal circumference is mainly contributed to by the liver. So this point gives us a picture of how our abdominal circumference usually ends up reducing, and usually fast. And as the fetus continues to be under stress, blood flow is diverted from less vital organs and redirected to preferentially to the brain. That's the redistribution, cerebral redistribution, which is discussed later. The coronary arteries, that's in the heart, and then the adrenal glands and the placenta itself. So that's response. So from this point on, I'll hand over to my colleague Eunice to take us through. Then I'll be back with another segment.
Thank you, Julius. That was quite elaborate. So we have two types of FGR, two phenotypes. That's the early onset FGR and the late onset FGR. Early onset is FGR that develops before 32 weeks of gestation. And late onset FGR is FGR that develops at or greater than 32 weeks of gestation. These two phenotypes are significantly different, and it's important to note which type of FGR you're dealing with because the differences also affect the management. So for the early onset FGR, it's more commonly caused by maternal vascular malperfusion, which is caused by abnormal transformation of the spiral arteries, and therefore they fail to become low resistance vessels, and that causes what we normally refer to as placental insufficiency. And as a result, we usually have changes in the umbilical artery Doppler waveform in the early onset FGR. It may occur in the late onset FGR, but not as common as it is in the early onset FGR. So the late onset FGR is the milder form, and it is characterized by non-specific placental lesions. And consequently, like we said earlier, they are not in all cases of late onset FGR shall we see changes in the umbilical artery Doppler waveform. The other differences between the two, and the ones that are really important to note, is that early onset FGR is really easy to pick on, but very difficult to manage, unlike late onset FGR, which is easier to manage than to detect. So most of the cases of late onset FGR actually go undiagnosed. And it's also important to note that early onset FGR is the more severe form, and it is associated with higher mortality than the late onset FGR, and it is usually associated with hypertensive disorders of pregnancy, the early onset FGR, unlike the late onset FGR. In late onset, we may or may not have hypertensive disorders of pregnancy. Also important to note is that early onset is less common than the late onset. About 30% of the cases of FGR are early onset and 70% are late onset. Okay, so moving on, we can't talk about FGR without talking about SGA. Small for gestation age fetuses are characterized by smallness below a predefined threshold, usually below the 10th percentile in the reference charts. And we must note at this point that most of the FGR fetuses are small for gestation age. However, not all small for gestation age fetuses are growth restricted. And also, not all growth restricted fetuses are small. Some are actually within the appropriate size for gestation age, but are at higher risk for perinatal mortality and morbidity, and therefore growth restricted. So it's important to know that not every small fetus that you see will be growth restricted, and we should also expect growth restricted fetuses within the normal range of fetal size. And the major difference between these two is that in growth restriction, the uteroplacental and fetal Dopplers are deranged, unlike in SGA, where the uteroplacental and fetal Dopplers are still within normal range. Okay, so for us to be able to diagnose FGR, we need to have a criteria and a definition for FGR. And internationally, the Delphi consensus is the most commonly used definition for FGR. And I must say that the Delphi consensus is used in absence of fetal congenital anomalies. That's a very important point to note. And it takes into account elements of fetal size and obstetric Dopplers. Like we said earlier, the obstetric Dopplers help us to pick on the uteroplacental function and the fetal cardiovascular adaptations to hypoxia. And therefore, they help us to differentiate fetuses that are small but normal from those that are small and growth restricted, and therefore at higher risk for perinatal mortality and morbidity. Yeah, so it's important to also note that the Delphi consensus also divides FGR into two: the early onset, which is below 32 weeks, and the late onset, which occurs after 32 weeks. And there are solitary indicators for each of those and combined indicators for each of those two subgroups. So for the early FGR, the solitary indicators of FGR are estimated fetal weight or abdominal circumference being below the 3rd centile, or absent end-diastolic flow in the umbilical artery. Anytime you see those before 32 weeks, those are obvious indicators of fetal growth restriction. Or you might have the abdominal circumference or the fetal weight being below the 10th centile, combined with uterine artery PI greater than the 95th centile, or the umbilical artery PI greater than the 95th centile. Either of those, 1 and 2, 1 and 3, 1 to 3. If you find any of those combinations, then that fetus passes to be diagnosed as growth restricted before 32 weeks. Then for the late onset FGR, the solitary criteria for FGR is estimated fetal weight or abdominal circumference being below the 3rd percentile. Anytime you see that after 32 weeks, that baby is, by all standards, growth restricted. Or you might have combined criteria where we have the SC or fetal weight less than the 10th centile, or the SC or fetal weight crossing centiles greater than 2 quartiles on growth centiles. So if you did, and this is especially in the 3rd trimester, if a mother did a scan, let's say at 33 weeks, and the AC was at the 70th percentile, and then 3 weeks later, at 36 weeks, it's at the 20th centile. We see a drop from 70 to 20, which is about 50 centiles. So that would be an indicator that this baby's growth trajectory is slowing down, and therefore that baby is most likely tending to growth restriction. Or also, if we have the cerebroplacental ratio being less than the 5th centile, or the umbilical artery pulsatility index being greater than the 95th centile, those are also markers for growth restriction in the 3rd trimester. And like we said, any two of those criteria and the combined indicators are enough to diagnose fetal growth restriction after 32 weeks. So how we're now going to see how we can diagnose FGR in a practical sense. So we need some tools, quote unquote, if we're going to be able to diagnose FGR. And the first thing we must always have is a baseline gestation age. A gestation age that was derived from a dating scan. And the best time to date a pregnancy is from 8 weeks to 16 weeks by CRL, which is the current gold standard, to 13 weeks, 6 days, which is the current gold standard for gestation age assessment. However, like we know and we've experienced, so many mothers show up later in pregnancy for their first ANC contact and for their first ultrasound scan. And therefore, at that time, after the first trimester, it is advised that we date using a combination of head circumference and femur length, or head circumference. And it's also important to note that transcerebellar diameter works just as well later in pregnancy. And the other tool we need, so we need a baseline gestation age from a dating scan. And then we also need an estimated fetal weight. And we recommend the use of Hadlock 3 formula, which uses SC, HC, and femur length to compute estimated fetal weight. So we need that as the other tool to be able to diagnose FGR. And then we also need the reference charts and the reference standards to be able to compare the biometries with the reference standards. We recommend the use of intergrowth charts for biometry centile calculation. And the reason for that is that the intergrowth study had a very robust methodology. It was an international study, multi-center, multi-ethnic. It had a large enough sample size. And the women that were recruited to be part of the study barely had risk factors for FGR or any abnormal growth for fetuses, and therefore the data was collected truly represents how fetuses should grow, unlike so many other reference charts that so many factors were not considered when creating them, and therefore we can't rely on that. Yeah, so the intergrowth charts are still the best to use because there was a robust methodology that was employed to come up with them. So we use those for the biometry centile calculation, and we also recommend the Fetal Medicine Foundation charts for calculation of the centiles of the umbilical artery, middle cerebral artery, cerebroplacental ratio, and the uterine artery PIs. We are going to have a practical demonstration of how to calculate the centiles when we're discussing the cases. But before that, we shall have Julius taking us through the Doppler changes in FGR. Sorry, before that, yes, just to complement what I had already said. So when a mother presents at the department, and at this point, we're assuming that we have done a baseline ultrasound scan, we've dated the pregnancy, and now at this point, we are doing fetal growth monitoring. So what we do, we ask for the EDD from the previous report, from the dating scan, and feed that into the machine. At the point we feed that into the machine, and then the machine automatically calculates for us the gestation age that day. At this point, I would like to emphasize that we should avoid redating. If a woman has done an earlier ultrasound scan, we should not redate the pregnancy again. We should just carry forward that EDD and we shall always use the gestation age by the first EDD. So after feeding that in and we've done all our biometry measurements, we now compare those measurements with the preference charts we are going to use. In this case, like we said, we advise intergrowth and see where those biometry measurements are lying on the growth charts. That will show us if the centers are within normal range or deranged, according to the definition we discussed earlier. And then also we compute the Doppler PI centiles for the uterine artery, umbilical artery, and MCA, depending on the gestation ages. We are going to see that later. Yeah, so I would like to hand over to Julius. Take us for the next part.
Thank you so much, Eunice. Julius, before you come in, I would like to run a quick poll just to kind of gauge and see our standing on certain aspects of what you've talked about so far, things to do with diagnosis of FGR. I'm launching a poll right now, and the question is, have you diagnosed fetal growth restriction using ultrasound before? That should pop up on your screens. So if you can quickly select a yes or a no and then submit your poll, I'll be telling you the results shortly. Do you people see the poll coming through? Yep, I see the responses coming through. Good. Ishaku, Somalia, greetings from Ghana. I see you. Could you please send your response through the poll so that the statistics are captured, not through the chat, but through the poll. We'll give it the next 2 minutes and then we'll proceed with Julius.
And please be as honest as possible. Yes, you could have gotten some hints right now, but be as honest as possible. This fetal growth restriction sometimes is quite a bother. But let's learn. More responses. We have over 70 people. At least if we could have about 20 to 30 people give a response.
Have you diagnosed fetal growth restriction with ultrasound before? Yes and no. So far, about 80% of the people have not diagnosed FGR before, and about 20% have. And this is quite surprising. I thought many of us had diagnosed her. This is a interesting, in fact. Keep the polls coming. Keep the polls coming. The next 1 minute, and then we go back to Julius.
We need about more 10 to 20 people to give responses. Keep the poll running. Keep responding to the poll. There'll be time for questions and answers. Don't worry. I saw someone raising a hand. Don't worry, we shall have time for questions and answers.
Good, good, good. And during the presentations, if you have a question, please type it in your chat. We'll see it, and then at the end, the presenters will answer your question. Some of the questions you sent through might be responded to during the presentations. I saw someone ask, what charts do you use to show deviations? That was Prince Ops. I think that that question was answered quite clearly by Eunice when she talked about the intergrowth 21st. So far, we have 18 responses, and it's still about 80% no and 20% yes. 19, 20 responses. I'm going to lock the poll, and then we'll allow Julius to tell us more. Thank you so much for the responses. So about 70% of us have not diagnosed FGR with ultrasound, and about 30% have. Let's see what the experts tell us. Over to you, Julius. Thank you so much, people. Thank you.
All right. Thank you very much. And thank you, everyone that has responded to the poll. So, regarding the Doppler changes in fetal growth restriction, we'd like to intimate on the progression of deterioration in each of the phenotypes. We want to acquaint ourselves fully with what to expect, when and where, and what to do at one point. So this first point summarizes that progression. If you remember what we talked about early onset, it's mostly, in most cases, it has been found to be a complication of maternal vascular malperfusion. That says a lot about this first point. So that actually indicates uterine arteries is where we detect the first abnormalities, and then later in the umbilical, then the middle cerebral artery, and then the ductus venosus usually changes, especially absent or reversed a wave is in severe forms of cardiovascular adaptations. In fact, changes in DV start to show you maladaptation. The fetus, things are going bad at this point. There's deterioration of, there is compromised hemodynamics of the fetus. And at that point, usually the DV. I also want to state earlier that in the subsequent slides, we are not going to mention anything about timing delivery. In as much as guidelines have said this, we're not going to talk about it. Dr. Daniel through the management, and so we want to refrain on basis of our country. Not we have not discussed at a point. There is no consensus between the sonography world and the obstetricians in our country, at least as of what to do with what. So we are going to refrain from mentioning timing delivery. So the uterine arteries, umbilical artery, and middle cerebral artery Doppler abnormalities represent early changes in fetal growth restriction. Increased umbilical artery PI usually typically leads the sequence of fetal Doppler alterations. Mark that, fetal Doppler alterations, not all Dopplers. So in this case, we talk about the umbilical, the middle cerebral, and then the venous districts of the ductus venosus. Even changes in fetal heart rate and biophysical profile modifications are all preceded by changes in umbilical artery PI. Cardiovascular deterioration is the end-stage complication caused by severe hypoxemia and subsequent acidosis. Usually, at this point, changes in the DV are apparent. And then the Doppler abnormalities may be present for many weeks before severe cardiovascular and metabolic deterioration occurs. This point, I think the implication of this is very good, especially on the fetal side, because as we shall realize later, the end goal of this is the intervention, which to date, the gold standard intervention for FGR is delivery. So this long duration between Doppler abnormalities and cardiovascular deterioration is good for the fetus, in that case for the mother, that at least the fetus can be given a little bit of time to mature before an intervention is executed. Absent umbilical artery and diastolic flow precedes critical fetal deterioration. So usually when you have absent or reversed end diastolic flow in the umbilical arteries, at this point the deterioration of the fetus is advanced, and probably an intervention needs to be executed. And then the progression from absent to reversed might be slow. However, that is not supposed to warrant delays because the absent and diastolic flow itself is already is already something that exposes the fetus to severe deterioration. So we wouldn't want to wait for reversal to happen before an intervention is executed. An important point to note is that umbilical artery pulsatility index does not become abnormal until about more than half of the placenta is dysfunctional. I'd also want to add to this that I read a different study that actually puts this at 30%. So that's a point to search out. And then for progression of deterioration in late onset, so owing to the pathophysiology of late onset, alterations in the umbilical artery, Doppler and venous districts are rare. Remember, in the we talked about this being milder forms of placenta malperfusion, very mild forms. So you might not get, and then the other thing is usually in late onset, what is what is more significant is decreased diffusion. You might not have a change in the flow volume, but then the diffusion of nutrients is compromised, so you can have compromised nutrients but with a normal flow volume. So in that case, we're not going to have alterations. Usually they are rare umbilical artery Doppler changes, and so in the vast majority of late onset fetal growth restriction cases, it's as we shall see later, the brain sparing effect or the fetal cerebral redistribution might be what we might pick. And there's a slide that talks about that in detail. So we're going to talk about surveillance and monitoring of FGR. We're going to start with early onset. And again, the goal of monitoring and surveillance here is timing delivery. And so I would love members to take note of the fact that we're not going to talk about timing delivery. Despite the fact that surveillance and monitoring is to help time delivery, I stated why we're not going to talk about the intervention when to time the delivery. I believe Dr. Daniel will handle aspects of that. So it's important to note that there's no existing consensus on surveillance frequency, like how often you need to monitor. And again, in this case, we are talking about an already diagnosed case of FGR, and the severity of fetal growth restriction and umbilical artery abnormalities form the basis for frequency of surveillance. So the more severe the changes in the umbilical artery, the more often you want to monitor. For example, if you have reduced end diastolic velocity in the umbilical arteries, with probably pulsatility index at 100th centile, you probably want to start to monitor very closely, just to make sure that just at that point when the end diastolic flow goes absent, maybe the obstetrician can start planning an intervention. So monitoring every 2 to 3 days is warranted in the presence of advancing umbilical artery abnormalities when there is absent or reversed end diastolic flow. The ductus venosus is a vessel that we want to look at critically in early onset, because as we stated in the previous slide, by the time this ductus venosus abnormalities, by the time abnormalities occur in this, then usually you have severe cardiovascular compromise of the fetus, and so an intervention would come in handy. BPP scoring is also important, and regarding BPP, it's important to know that loss of fetal gross body movements, along with ductus venosus pulsatility index alterations, can predict a fetal cord pH of less than 7.2, while loss of fetal tone is associated with a pH of less than 7. I know Dr. Daniel and the rest of the team of probably obstetricians around here know the implication of these pH values. For late onset FGR, our main vessel of interest is usually all vessels are important, but then changes are usually picked in the middle cerebral artery. And so for that, the middle cerebral artery pulsatility index and the cerebral placenta ratio are the most important Doppler parameters in the surveillance of late FGR. Cerebral redistribution sometimes is the only change noted is the only Doppler abnormality you could detect in late onset in the presence of even normal estimated fetal weight or abdominal circumference. As my colleague Eunice intimated earlier, not all appropriate for gestation age fetuses are not growth restricted. So, and then if umbilical artery pulsatility index is greater than the 95th percentile, monitoring at least once or twice a week is indicated, because at this point you don't know how fast the placenta is dysfunctioning, and so you can't predict exactly how fast it from reduced to absent end diastolic flow events might occur. 24 hours interval is recommended to reassess middle cerebral artery pulsatility index when cerebral redistribution is observed. We recently had a case of such. A lady had redistribution. We actually, I think, gave her about 15 hours. It was evening. She came back in the morning, and yeah, it had resolved. So sometimes, and she was appropriate for gestation age. So follow-up is very critical in some of these cases. And despite the association of cerebral redistribution with adverse short and long-term perinatal outcomes, there is currently no available evidence as to how cerebral Doppler should be utilized in the delivery timing of FGR. It's absurd, but I believe there are studies undergoing to bring sanity to this disparity. So let's look at biophysical profile monitoring in late fetal growth restriction. I want to state, first of all, that BPP is not as important as it is is not as important in late FGR as it is in early onset, and the reason is that it has been observed that BPP becomes abnormal usually only shortly before stillbirth, and therefore is not useful in determination of monitoring intervals. So this point also suggests that in as much as late onset is mild, and it's the fact that its challenge is detection is usually very poor and easily missed. This point also suggests that when that late onset can actually be as fatal because it only takes a short time for stillbirth to occur. So I think our obstetricians are noting some important points from some of these things. So let's talk about cerebral redistribution. It's also called the brain sparing effect, and
Maybe just a small interjection before you proceed. Just a minute for breather, both for you, the presenters, and for people to digest the information so far we have given them. My colleague is going to run a poll for another question. But in the meantime, I just want to give a brief, just one example that can explain what fetal growth restriction is. Imagine you are locked in a single room and the only entry for air, for your oxygen and food is just one entrance. Now, if you are denied from food, but you're getting oxygen, just imagine what happens to you. Yes, you're getting oxygen, but they're not giving you food. Just look at the scenario that will happen, all that. Or you are given food, but denied oxygen. What would happen to you? Or what happens to human life? You are given oxygen, but denied food. Or you are given food and denied oxygen. Now start looking at the events that will happen to you in that corner. It could even be as much as difficult that you are denied both oxygen and food. So your body is lacking nutrients, it is lacking oxygen. Honestly, there's no way you're going to survive. But death is not spontaneous, it comes through different processes. And that is what these colleagues are discussing. So just imagine yourself in that single room, you are imprisoned there. There's only one entrance. Now in this entrance is the placenta. So it's the placenta that will have to feed you with nutrients through blood, and it is the placenta that will give you the nutrients and the oxygen. Now imagine you are not excreting. So it's all of it, all that, look at it at the individual level. If you are locked in that room and you are denied either oxygen or nutrients, what happens to you in the run? And what are the processes that lead to eventually if you are deprived for any of these? The poll question has been sent. Edwin, over to you.
Thank you so much, Vitus. I've sent out a poll and it says if you've diagnosed FGR before, what did you basically use? Did you use EFW? Did you use AC? Did you use FL? Did you use BPD and HC? Maybe EFW and Dopplers? Maybe all the above. What did you use to diagnose? Maybe I should have added an option of saying other so that you can tell us what other thing you used. You could have used Fando height. So please tell us what you used to diagnose the FGR. The poll, I've already launched the poll. I don't see any responses at the moment. Please go through and give us some responses. Good.
Yes, we had 30% of respondents saying they have diagnosed FGR, and about 70% have never diagnosed FGR. So most likely we expect responses from the 30%. Okay, the responses are coming in. Continue. Dr. Paul Mwanguzi says the options are limited in scope for the small baby. Really? Okay.
I tried to create as many options, but then I didn't want the list to be so long. That's why I was saying I should have put other so that people can go ahead and but I completely understand what it's saying.
So Dr. Paul Mwanguzi, yes, indeed.
Farouk Osman says the poll is not responsive. I don't know why that is. Try going through your chat. There should be a poll that is responsive in the chat itself.
There's also a question by Abid Usman. Teddy was asking, is biophysical profile important in early onset? I think this was clearly stated. It is more important in early onset than late onset. Farouk says, never mind, it's now working. Okay. So I think the response, okay, Flavia Navafu, it is now responsive. Okay, great.
Should we close the poll, Vitus?
Just about 40 seconds.
Okay. So far, we have the majority of you saying it's by EFW and Dopplers. And one person used BPD and head circumference.
Okay, it seems there's no more polls coming in.
Okay, female language.
Teddy has a question. I think BPP has no role in diagnosis of early onset. Maybe you missed a point there. It is not a parameter used for diagnosis of FGR, but it was said in some centers it is used as a means to determine delivery. Most obstetricians will seek for biophysical profile in determining when to deliver this baby who is growth restricted. So BPP will be used when already FGR has been determined. But the discussants were saying BPP in late onset might not be as sensitive as when it is early FGR. Marion says, many times I've encountered requests for fetal Doppler for mothers at term in labor. How important is it? Maybe that will be answered later on if you keep monitoring the next discussion, but it depends which Dopplers are being requested. Otherwise, we might request for valvular Dopplers, fetal cardiac valvular Dopplers. So I think maybe your question intends to know which Dopplers are being requested for. So Edwin, I think the poll can be closed, and over to you, Julius and Eunice, proceed.
All right, okay. Thank you, Veritas and Edwin. So we're discussing this cerebral fetal cerebral redistribution in left FGR. We said it's also called a brain sparing effect, which is a hemodynamic response where vasodilation of cerebral vascular beds occurs in response to hypoxemia, and that's what defines the brain sparing. You're trying to spare the brain, and yeah, it's initiated via the direct vascular sensing of oxygen tensions in the cerebral circuit. Point to note is it's not only redistribution doesn't only happen to the brain. There's also it's also redistributed. Cardiac output is also redistributed to the heart, specifically the coronary arteries and the adrenal glands. So, what would we expect to find, for example, in cerebral redistribution? A reduced middle cerebral artery pulsatility index, um, elevated. Now, this second point is very, very, very subjective at times. The elevated MCA EDV, those that have used it know it. When it's there, it's obvious. However, sometimes the EDV is not significantly elevated, but the CPR, the cerebroplacental ratio, can help indicate that possibility. And the reason I stated this elevated MCA EDV is I just want us to take just a minute to discuss this case of 37 weeks, 3-day appropriate for gestation age fetus with MCA PSV, middle cerebral artery PSV at the 64th centile, with an EDV in that MCA still of 37 centimeters per second, pulsatility index of MCA at 1.46, which is at the 23rd centile. That's by the FMF charts. And then umbilical artery PI at the 68th centile. Now, the reason I've brought this case is because fetal anemia, I've seen, we saw this case, fetal anemia can actually mask, if you want to strictly use pulsatility index, fetal anemia can actually mask it. So if you have a situation where you have both anemia and hypoxemia, so you're going to have the anemia causing elevated peak systolic velocity in the MCA, which we see here. It was the 64th centile. For those that might not understand what I'm saying, so MCA PSV as a solitary parameter is a good indicator for fetal anemia, especially if it goes beyond the 50th the 50th centile, or more than 1.5 of the mean. At this point, one of the things we haven't included in our presentation is the technical aspects, because when it comes to performing the Dopplers, there are a lot of nitty-gritties, a lot of corrections to make, a lot of things to take care of. So everything we have discussed is on the assumption that the technical aspects are handled appropriately. The angle correction, the wall motion filter, issues to do with compression, which point to sample, and all that. That's a whole other discussion. So with everything we are presenting, we are assuming an ideal circumstance where everything is done appropriately. Otherwise, PSV can also go high because of probe pressure. So this was a case that was tricky. So MCA PSV was at the 64th centile. This was done about 3 times, and it was varying between that and the 67th centile. And the EDV was also elevated. It was at the 37 centimeters per second, and the PI was normal in the MC as well. So you realize at this point you can't use these are rare cases. I have to say they are rare cases, but it's a very good thing to know that things can occur concurrently, and that one thing can mask the other. So it's important to know how to make distinctions in these. So we just stated a few scenarios that could come up in while you're doing your obstetric ultrasound. So you could get a small for gestation age with a borderline, sorry, this is incomplete, with a borderline Dopplers, let's say for the fetus. So you could have small for gestation age, and umbilical artery at the 94th centile. So decisions have to be made, and in this case, we recommend follow-up. It could probably mean things are going out of hand. You could have appropriate for gestation age, still with borderline Dopplers. You don't ignore this just because this is appropriate for gestation age. It could still mean that there is progression of events that could end up catastrophic. We could have small for gestation age with normal. This is this is interesting. Small for gestation age with normal umbilical and middle cerebral artery Dopplers, but with abnormal uterine artery pulsatility index. So this is a case. We had a similar case just the previous week. So that this looks like a case of small for gestation age at risk for fetal growth restriction. The umbilical artery PI was at the 100th centile, but I mean the uterine artery PI was at the 100th centile, but the umbilical and middle cerebral artery pulsatility indices were very well within range, not actually borderline. So this was something we scheduled for follow-up. And then you could have appropriate for gestation age with abnormal umbilical artery pulsatility index, but normal uterine and middle cerebral artery pulsatility indices. Again, we've seen such a case at about 36 weeks, where the uterine and the umbilical artery PI repeated measurements was high. Yeah, I've actually come across studies which were particularly studying this condition of AGA with abnormal umbilical artery. And point to note is that both studies actually concluded that these are still at risk of adverse perinatal outcomes. So when you see this and you know your technical applications were okay. I don't know how we reconcile this with obstetricians. That's one of the challenges we shall talk about later. So I'm going to hand over to Eunice to take us through a couple of cases that we want to discuss with the team. We are hoping that we have not flooded people with a lot of information that they can't digest. And I don't know, I'm asking Vitus, I don't know if it's possible for people to first, I don't know, ask and do, I don't know. Before we go to these cases, I think people need to refresh the volume of knowledge they've received.
Okay, over to you, Edwin.
Yes, I'm going to quickly launch another poll. Sorry. Yeah, I'm going to quickly launch another poll asking about the Dopplers. And you should have received the poll right now. It says, which Dopplers can you confidently perform? Here you can select, if you do all of them, you can select all of them. If you do one of them, you can select just one of them. But please tell us which Dopplers you can confidently perform.
As the responses are coming in, Edwin, I'll direct you this question from someone. In circumstances that one notices the dating was done poorly, is it acceptable to redate the pregnancy? How does someone move about with such?
You have to define poorly.
Yeah.
You have to define poorly. It's a challenging thing. It's like saying, if I can't find an appropriate example to give to you right now, but if the dating was done poorly at the beginning, it affects everything along the line, because you'll notice that most of the things that we do in obstetric ultrasound depends on the dating scan. There's nothing you can call normal if you did not date properly, because everything depends on size, and the size is in relation to gestational age. So if you have a wrong gestational age, it means you have a wrong size of the baby. So everything is in response to a reference which is set by the dating scan. You cannot say, oh, this heart is normal size for 22 weeks or for 24 weeks. You can't tell if you did not date the pregnancy. You cannot say the head is normal size. Normal size for what? So even some structures of the baby that do, some anatomy of the baby that does appear much later in the pregnancy, you really can't say the brain is normal or abnormal if you have not dated the pregnancy correctly. Now that said, if you say if the pregnancy was dated wrongly, is it okay to date it appropriately? I would answer that by saying it depends on how much error you're risking to include when you're dating this pregnancy. So for example, if you look at a pregnancy, it was roughly dated at first trimester by CRL, and the baby was not really in the good position, although the person went ahead and did the measurement. You're seeing this patient again at 36 weeks. And you ask yourself, should I date this pregnancy again with head circumference, or should I leave it as it was at the first trimester scan? The question would be, if you go by that first trimester scan, and for, granted there was dodgy measurements done, the error in that would be maybe a week plus or minus. But if you redate the pregnancy with head circumference at maybe 37, 36 weeks, what is your error margin? You're looking at about plus or minus 20 something days. Is it worth it? Should be the question. You could look at doing averages, maybe average head circumference, femur length, and abdominal circumference, mostly head circumference and femur length. You could look at TCD. The truth is, once something is done wrongly, it affects the management. So it is better to not think of correcting the wrong things, but trying to now doing preaching the gospel of doing the correct things. Date the pregnancy properly, because there's no medicine for a wrongly dated pregnancy. That is what I would say.
Thank you, Edwin. Dr. Paul Mwangzi, I see your hand is up. Maybe you can unmute your microphone and then. Okay, Dr. Paul,
I'm going to unmute his microphone if he wants to ask. Ask me one question.
Okay.
1 second, sorry.
Meantime, Eunice and Ojetre plan to wind up so we can have Dr. Daniel.
Okay. I've unmuted your microphone now.
Dr. Paul Mwangzi, your question?
You can go ahead.
Dr. Paul, you have to unmute the microphone on your side as well, then you can ask your question.
He says he has no access to the microphone. You can type your question in the chat.
Okay, let me see.
So the polls so far, I think the majority of the people have done umbilical Dopplers, at least 40%. About 30% have done uterine Dopplers. About 25% have done MCA. A very small percentage, about 6%, have done ductus venosus. This is good.
Dr. Paul has no question, but has a supplement. That's great. Maybe you can go ahead and type it in the chat. Okay, so I think that's the responses. Maybe you can be back to Julius and Eunice. You can give us the case as we try to wind up. We are left with a few minutes. We need to hear from Dr. Daniel.
Vitus and Edwin. Okay, so we have 3 cases, one for early onset, late onset, and a tricky situation. And so case 1 was a prime gravida. She had done her dating scan at 20 weeks 1 day along the course of her pregnancy. Actually, she came for routine antenatal care, had absolutely no complaints. However, it was noticed that her BPs were really, really high. And so she was admitted and she had a scan done. And so we did the scan. And like we said, what we do is we simply input the EDD from the baseline scan to give us the gestation age that day. So that day she was at 34 weeks 1 day. So went ahead and did the biometry measurements, and this is what her report looked like. And as you can see, on the right hand side of the report is where we are having the gestation ages by the different biometry measurements, and we are seeing that they are most of them, except for the cerebellum, 4 weeks, which she's at. And usually that's the first telltale sign that something could be going amiss. And then just next to that on the left, just next to the gestation ages by the different biometry measurements, we are having those percentages, less 11. Those are the centiles by Hadlock, I must note, by Hadlock. But like we said, it's recommended that we use intergrowth for the reasons you stated earlier. And though, however, I must say that if Hadlock already gives you something less than you to check on intergrowth and then see where it falls. So we can see that all the biometry measurements except TCD were well below the right gestation age, which was 34 weeks 1 day. And special emphasis there is to say that FGR cerebellum measurements will be close to the actual gestation age. And the reason for that is the fetal brain sparing effect that Julius had talked about, that in fetal growth restriction, we have blood being preferentially brain, and therefore the brain structures are expected to be growing as they should. So that's why the cerebellum still gives us a gestation age close to the actual gestation age. So we did that was the biometry, and then we also did the Dopplers, the umbilical artery, MCA, and the uterine artery. And that's what the umbilical artery on the left looked like, and the middle cerebral artery on the right looked like. As you can all see, we had a reversal in the umbilical artery, reversed end diastolic flow. Can you see my cursor? Can you see my cursor?
You can try to move it again. Oh, yes, we can see it now. Yes.
Okay. So this is the umbilical artery waveform, and this is the systolic component, and this is the diastolic component. And we are seeing that the diastolic component is below the baseline, and that is what we refer to as reversed end diastolic flow, which is one of the last stages in the progression of FGR. And then we also see that we sampled the right middle cerebral artery, but we are seeing that the diastolic component is quite elevated, which is not what it should be like for an umbilical artery, for a middle cerebral artery waveform. And consequently, the PI for the middle cerebral artery was low. Yeah, so qualitatively, we can see that the end diastolic flow is high, and then, of course, that prompts that we look at the charts and be able to calculate the PI. And then we also, of course, because this was 31 weeks, early onset, it would also be good to look at the uterine artery, which also features in the definition of FGR for early onset. And the first feature that we see is the early diastolic notching, this here. This is the right uterine artery, and this is the left. So both of them had the early diastolic notch, which is a feature that shows increased resistance in the uterine arteries. So at this point, I'd want to demonstrate to us how we can practically calculate the centiles for both the biometries and the Dopplers to be able to come up with exact centiles and be able to accurately qualify the baby for FGR or not. I hope I can be able to do that.
Has been noted. The end is time to wind up them.
Can you see my screen?
Maybe you can tell us, yes, we see you have opened Mr. Google and you have typed in FMF. What is FMF?
FMF is Fetal Medicine Foundation, sorry. You would go to your search engine, type in Fetal Medicine Foundation Doppler calculators. Internet is a bit slow. I really request that we are patient, as this is very important for us. And so it will bring those options. Particular interest is that first one for assessment of fetal Doppler. However, for this case, we must note that we did not quite need it for the umbilical artery because there was already a reversal, but that's how the page would look like. So you would have to input the, maybe you can input for that, just really, this is really just for demonstration. The gestation age was 34 weeks, 1 day. I will repeat, we do not redate the pregnancy. This gestation age was calculated from the baseline scan. Yeah, so because we already had reversed, we shall not put a value from umbilical artery PI. Again, this is really just for demonstration. Then we put the value for the middle cerebral artery PI.
I seem to have lost.
You can't see my screen, Vitus?
Okay, now it is visible.
Okay.
Maybe start again from patching in the gestation age.
Okay, so this is how the screen would look like when you type in Fetal Medicine Foundation calculator and then you go to fetal Dopplers, assessment of fetal Dopplers. So it brings a screen like this and you're required to input the gestation age, the umbilical artery PI and the middle cerebral artery PI. And then the calculator will compute for you the centile and the cerebral placenta ratio. So like I said, for this particular case, the pregnancy was at 34 weeks and 1 day and we put that in. And then because we had reversed end-diastolic flow, it really isn't important for us to fill this, the umbilical artery PI part, but again, just for demonstration, I'll fill the middle cerebral artery PI part, and the middle cerebral artery PI was 1.1. Yeah, so when you fill that, it gives you the Z-scores and the centiles, and as we can see, it was at the first centile, and already that's a sign of redistribution. Yeah, so this is it for the Fetal Medicine Foundation calculator. And we can also use Fetal Medicine Foundation calculator still for the uterine, to get the centiles for the uterine artery PI. And we must note that since we have the right and the left uterine artery, we get the PIs for each and get the average, and that is the one that we fill in the calculator. Okay, so this is what the screen would look like for the Fetal Medicine Foundation calculator for calculating uterine artery PI. Again, you fill in the gestation age, that day, and then the uterine artery PI. So for this particular case, the left uterine artery PI was 1.37 and the right was 1.24 and the average was 1.305. So it is the average that we input here. I hope we can see my screen. Can we see my screen?
Yes, we can see it.
Yes, we can.
Okay, so when you do that, the calculator computes for you the Z-scores and the centiles. And if you can remember from our definition of FGR, by the Delphi consensus, when we have an umbilical uterine artery PI greater than the 95th centile, with either SC or fetal weight less than the 10th centile, that baby passes for fetal growth restriction. So in this case, we're having uterine artery PI at the 100th centile. So let's see what intergrowth would give us for the biometries. So again, you go to your search engine and then you type in intergrowth fetal charts. Trying to be fast, but the internet is pretty slow.
As Eunice as Eunice goes ahead to prepare that, I want to recognize in a special way the presence of Dr. Sam Ali. Dr. Sam Ali is an executive associate of Makerere University Hospital. Interestingly, he's my boss and the boss of today's discussant. Dr. Sam Ali has vast experience and research in fetal maternal medicine. Dr. Sam, welcome to this discussion. We look forward to listening from your expertise.
Okay, so like we said, you type into your Dr. Sam, you're very welcome. I'm glad that you made it. Yeah, so as I was saying, you type in your search engine, intergrowth 21st fetal charts, and particularly we are looking for the ones on fetal growth. Which is the second option here. Okay, brings us to this screen. Then if we are doing it online, we must, you can either have it online or you can have an offline calculator. So for today, we're doing it online. So you come to calculators and apps, and then you open up in web browser. Brings us to this screen. Then you choose the option of entering the data manually. Okay, so this is the screen you're interested in. At this point, we can enter our gestation age and the different biometry centiles. So the gestation age was 34 weeks, 1 day. So you simply just click and then to come in orange and enter the biometry centiles. So head circumference was 81.30. The BPD was, sorry, this was BPD. 81.0. Was 285.50. Following, this is a very important step. OFD was 100.60. Abdominal circumference, which is particularly very important here, was 232.65. Femur length was 53. 70. filled in your biometries, you compare to standards, and this is where now the calculator compares for you the biometries you've input, which you've got that day, with the reference standards. So when you click it, okay, so I don't know why the internet is being really slow, but then yes, so we get this tabular format. This, I hope you can also where my cursor is. The calculator computes for us the z-scores and the centiles for each of the biometry measurements, and it also gives us a graphic format for each of those depending on which one you've highlighted. So as we can see, we are going to concentrate on the centiles. Each of the centiles is below the 10th percentile, which makes this baby symmetrically small. And special interest is given to the abdominal circumference, which is in our criteria for defining FGR. We can see it's at 0.00 centile. That means it was really, really, really low for gestation age. And like we said in the definition for FGR, when we have either abdominal circumference or estimated fetal weight being below the 3rd percentile, that baby automatically passes for FGR. So for this baby, we didn't even need to look at the Dopplers. By just the biometry, SC was below the 3rd percentile, and therefore it was growth restricted. So this mother had an emergency C-section, delivered a baby at 1.3 kilograms. The baby had respiratory distress syndrome and was admitted to NICU. Thankfully, the baby made it out alive. Yeah, but we can see the relevance of, adding Dopplers to the biometries to be able to really pick on the babies that are truly growth restricted. And remember that this mother just walked in for antenatal care. She had absolutely no complaints. So it was a very interesting case. Yeah, that was case 1, and I think we can.
Okay.
I hope we've been able to
go through the cases so that we have time for.
Okay, that was case 1. This was the other case. Again, she was a prime gravida, dated at 14 weeks 5 days by head circumference and FL. Unfortunately, developed PE and
What's PE?
PE is preeclampsia, characterized by high blood pressure and proteinuria after 20 weeks of gestation. So again, when she came in, we input her EDD, which gave us the gestation age that day to be 36 weeks 5 days. This was well into the 3rd trimester. We did the biometry measurements, and this is what her report looked like. This is what her report looked like. So again, we fed those biometry percentiles into the intergrowth calculator. And we found that SC was below the 10th percentile, and the rest of the other measurements were between the 10th and the 90th percentile, which is normal. And also looking at her Dopplers, qualitatively, we can see that there's reduced end diastolic flow in the umbilical artery, which is a sign of increased resistance. And we can also see that there's subjectively increased end diastolic flow in the left middle cerebral artery. So again, we fed those into the Fetal Medicine Foundation calculators. and we found the umbilical artery PI to be at the 100th centile. I will not repeat, I hope we really followed in the first example, but we found the umbilical artery PI to be at the 100th centile and the middle cerebral artery PI to be at the 2nd centile, and the CPR was at the 1st centile. And if you can remember from our definition of FGR, late onset FGR, we said that when you have either SC or fetal weight being below the 10th centile, with either umbilical artery PI being above the 95th, CPR being below the 5th centile, or a baby crossing centiles, we can pass that baby for FGR. And so from this, we see that the baby was growth restricted on the basis of an SC below the, SC was at 7th centile, an SC being below the 10th centile, and the umbilical artery PI being above the 95th, and MCA being below the 5th. So this baby was also fetal growth restricted. And that was at 36 weeks, but this mother pushed on with the pregnancy till 39 weeks, delivered a baby who, interestingly, the APGAR score was normal, baby was normal, yeah, but it was still growth restricted. But I think we can now appreciate that late onset FGR may not be as severe as earlier onset FGR. The outcomes may not be as bad. Yeah, and then we had an atypical case. An atypical case. The mother was a gravida 5 para 2 plus 2. She also developed severe preeclampsia, and because of that, she was sent for ultrasound scan. So we did the ultrasound, did the biometries, fed those into the calculators and the Dopplers, and it was interesting to see that the biometry measurements were all within range. Nothing was below the 10th percentile. However, this is what her Dopplers looked like. This was her umbilical artery, this was middle cerebral artery, and these were her uterine arteries. So as we can see, subjectively, there was a reduced end-diastolic flow in the umbilical artery, which again is a sign of increased resistance. And there was notching noted in both uterine arteries, early diastolic notching. Yeah, so again, as per protocol, we had to feed those into the calculators. Yeah, we fed those into the calculators, and we found the uterine artery PI to be at the 100th centile. We're looking at it now because this was before 32 weeks. And in our definition for FGR, we said that below 32 weeks, we look at the uterine artery PI to see if it is below or above the 95th centile. So we found it to be at the 100th centile, which was above. We found it to be at the 100th centile, which is above the 95th. And and the umbilical artery PI was also well above the 95th centile. However, like we said, this was atypical because the biometry centiles were within range. So we couldn't, by intergrowth, you can't confidently say this is growth restriction, but you know there's a problem for sure because the Dopplers are deranged. So because she had severe preeclampsia, she was delivered by emergency C-section, and yeah, the baby was alive. However, it had asphyxia, was admitted to NICU, and unfortunately, the baby died the next day. Yeah, so those were the 3 cases we had, and I hope we've been able to appreciate how to use the different tools for diagnosis of FGR, both in the early and the late onset. And I hope we can always be able to remember the criteria for diagnosing FGR. And I must note that there are challenges to diagnosis of FGR, especially in the African context. It's not as easy as we probably made it seem like, for a number of reasons. One of them being the equipment that we have. Not very many facilities and centers have equipment that can, on which Doppler examinations can be done. And like we've seen, Doppler is very, very pivotal. Doppler studies are very pivotal in the diagnosis of FGR. So if our equipment are not able to do that, that will for sure be a challenge. And then also the technical knowledge. We've just seen from the poll that there's quite a huge number of people that are not yet conversant with the obstetric Dopplers, and that again poses a challenge in FGR diagnosis. And then there's so many reference charts and ranges that are available with significant discrepancies, and therefore what one chart can pass for being below the 10 percentile, another chart will pass as normal. And so therein, there's a lot of discrepancies in diagnosis. And it's also important to note that not very many countries, especially in Africa, have national policies or guidelines that streamline the diagnosis of fetal growth restriction. So what that leads to is that every practitioner, sonographers, obstetricians, is sort of left to judge the matter and do as they judge best fit. And at the end of the day, we don't have like a unified standard of diagnosing FGR. And also, the fact that there are not very many national based studies, sometimes we use reference ranges for populations that are not in our settings, and that there could be differences in populations. So if we're not using charts for our populations, that could also bring problems. And it's also important to note that given the fact that most of our mothers show up in the second and third trimester, there was a meta-analysis done that showed that just about 37% of mothers show up for antenatal care in the first trimester. And so the rest of the 63% that are coming later are coming at a time when it's harder to determine gestation age. And like we said and have seen, it is very a correct gestation age assessment is very necessary and very important if we are to accurately diagnose FGR. And also, it's also important to note that the gestation age assessment methods we're currently using have quite significant margins of error. And therefore, again, if we can't establish a gestation age close to the right one, then we may not be able accurately to pick on fetal growth restriction. So those are some of the challenges, and there are gaps, there are areas for research, there are areas that question our policies. Yeah, and we hope that in the future, they'll be better. Thank you. Those were our references, and we want to, in a special way, thank Dr. Sam Ali for allowing us to use the cases that we shared today. Thank you very much, Dr. Sam. Thank you, Vitus. That is it from us.
Wow, wow, wow. Thank you, Julius and Eunice, for this excellent presentation and work. We are immensely grateful for this wonderful work. Again, we extend our appreciation to Dr. Sam. Maybe later on, Dr. Sam, I'll give you a few minutes. I know you are an expert and you have done quite extensively a lot of research work about Doppler's use of Doppler in obstetrics. We thank you for permitting Julius and Eunice to use these cases to pass on knowledge and to enable our colleagues. We thank you very much. And maybe we are also thankful to Ultrasound Africa for giving a platform to people who can share knowledge and share experiences. In the meantime, Dr. Daniel, as you could be preparing to share your slide, and we'll have more of the discussion after Dr. Daniel's presentation. That is in the interest of time. Dr. Daniel is a consultant obstetrician and apparently works both with Kawempe National Referral Hospital, and he also works with Makerere University Hospital in one of the leading researches in the obstetrics. So Dr. Daniel, over to you. You could share your slide and start sharing. Colleagues, the next phase will be a little bit faster. Now, before Dr. Daniel comes in, there is a poll that has been sent in. Over to you, Edwin.
Thanks, Vitas. I've just sent in a poll asking, does your country have national guidelines on diagnosis of fetal growth restriction? It should have come up as a pop-up, or you could check your chats and you'll find it on there.
Okay, Dr. Daniel.
Yes, I'm sharing my.
Okay, great.
Is it there? Have you seen it?
At the moment, no, we don't.
You don't see it?
No, we don't see it.
Ah. You still don't see it? I'm just holding my slide. Do you see it?
No, we don't. Did you use the share button on the top of the screen? There's a share button on top of the screen that you could use.
Yes.
Dr. Daniel, you could use the share button.
Yes, it's what I'm trying to.
Yeah.
Sorry about that glitch.
No worries at all.
Huh? Do you see it now?
For some reason, we don't.
Ah.
If you're using a computer with 2 monitors, drag the presentation to the second monitor.
Let me send it to Vitas. Can I share it with you?
Yes, it's okay. Yeah. It's okay. You can send it over to me.
Yes.
In the meantime, Edwin, you could be going through some of the questions that were sent in the chat box as I download the presentation.
Sure. There are lots of questions in the chat. Yep. Isaku, you said you have questions. Please go ahead. Let's see.
Vitas, you should have received it.
What are the normal ranges of the Doppler, or do they range with the weeks of pregnancy? That's a question from Sydney. What are the normal ranges of the Doppler? Or do they vary according to gestation? The quick answer to that is yes, they do vary according to gestation. What is normal at, say, 24 weeks might not be normal at 30 weeks, and so on. If there is brain sparing, why aren't BPD and head circumference parameters normal and only the TCD is normal? That's a question by Nachiwala Catherine. That's a good one. I don't know if there's anyone going to answer that, but I can quickly say that the human body is made in such a funny way that there are areas or parts of the body that are preferential. So they are held with more importance than other areas, and the same thing applies to the brain. Of all the brain tissues, the cerebellum is spared compared to other parts of the brain. I don't have the physiological reason for that, but that's why it's less affected by growth restriction. And that's why the TCD, the transcerebellar diameter, will tend to be normal even when the head is shrinking, in quotes. I have a question. What is the percentage of error in diagnosis of FGR in relation to techniques of acquiring the Doppler? That's a question by Noah Cora. I will let my colleagues answer that for you. Teddy says, I think IUGR masks anemia more than anemia masks IUGR. I think the point here was that with anemia, you have spiking of the velocities, which in a way kind of improves the PI, which you would have otherwise used to say there is brain sparing. So if you have anemia, basically even what you're saying is roughly correct. But if you have anemia and then you have elevated peak systolic velocities in the MCA, leaving the end diastolic velocities low, it kind of helps improve the PI, which is the pulsatility index. And if you're relying on the pulsatility index to kind of help you confirm fetal growth restriction, then anemia in that way will mask the growth restriction. That was the point. What if someone did not do the dating scan? This is a question that keeps coming up so many times. What if someone did not do the dating scan? What do you do? Well, if someone did not do the dating scan, you do the dating when they show up. If a person shows up at 36 weeks for their first scan, you won't chase them away and say you did not do a dating scan, go home. You'll date a pregnancy at 36 weeks. But then you're working within the limitations of saying that dating a scan at 36 weeks comes with a huge error, an error in dating. And what you might actually be looking at might be either a small baby or a big baby, but you'll never actually know because the patient is presenting late. If the patient comes early in the first trimester and you're able to do CRL, it would be more accurate. So what I would do as a person, as a practitioner in that case is, number one, I would do the scan, but number two, I would educate that mother and make sure that on top of the scan, she gets the knowledge of why it is important to have a first trimester dating scan.
We have lost the chair.
Vitus, are you there?
Dr. Daniel, I'm going to share
Yes.
just straight away.
Yes,
start.
sure. Yes.
Okay. Okay. Okay, here we go. Dr. Daniel, you can proceed.
I don't see your screen.
Okay, it will come shortly. Edwin, are you able to see the screen?
I don't see the screen. I don't see the slides, Vitus.
Oh. What is not happening?
Technology is betraying us. But it's a great opportunity for us to hear from an obstetrician, because most of the times we get a one-sided point of view. We get a sonography point of view of FGR. We never know what happens after our scans. We don't know what happens when we miss or when we misdiagnose fetal growth restriction. So it would be a very great opportunity to hear from Dr. Daniel, because then we get the other end of the spectrum. So we get to hear what happens when the patients leave our side after the scans and go to see the obstetricians. And maybe we can also learn from them what they expect from us and what we can do to improve on our side. It would be a nice take home to hear from Daniel, the management side of things.
Edwin,
Yes,
still you
please.
can't see my screen?
I still
can't
don't
see a
see
screen.
I still don't see a screen. I don't know why, but I still don't
Okay,
see us.
I've forwarded the slide to you. Maybe you could share from your side.
Okay.
As you download, Dr. Daniel, you are still sharing because I can see your
No.
screen is still popping up.
I'm not sharing.
It's not sharing. How did you forward it to me, Vitus? Did you send it?
Yeah, I have done. Apologies for those technical glitches. In the meantime, we want to recognize the presence of our founding CEO, Mr. Tugume Benjamin. Maybe Edwin, as you try to get up that, could we get 1 or 2 minutes from Dr. Sam? He's an expert at fetal Doppler. Dr. Sam, let me see if we can mute your microphone. Okay. Dr. Sam, your microphone has been unmuted. Maybe before Dr. Daniel comes in, you are an expert at fetal Doppler with extensive and vast experience and in research about this topic. You could give us 1 or 2 guidelines on this fetal growth restriction. It is an elusive topic and not known in our context and setting.
Yes, thank you, Vitus, for the opportunity to say a word or two. And I want to thank the presenters for giving such an excellent talk. We are very proud of you and Ultrasound Africa for organizing this webinar so that at least you can improve practice across the globe. I can see the invitation usually goes beyond just Uganda and Africa, but I also other experts from other countries like the UK also do attend these meetings. It's very good of you, and this is very good, a very good initiative. Really not much to say, but I want to just appreciate the content that has been prepared. It's been very extensive. It shows how much homework and detail you put in the preparation. Just to emphasize what everyone has emphasized, the aspect of dating is very crucial. So you need to have a proper understanding for the best methods that you can use depending on the window at which you see the woman maybe for the first time. If it's early pregnancy, maybe in the first trimester, then you want to choose a very good method like the CRL. Then the mid trimester, you want to consider what gives the lowest error margin. Then as you go late in pregnancy, it gets quite complex, but you can still think about using those late gestation age assessment methods. But at any one point that you see a woman and you're thinking about fetal growth restriction, a nice dating scan is very crucial. And like you guys have already demonstrated, like fetal growth restriction may be independent of just size. So it's nice to look at functional parameters. Some of it is Doppler that you demonstrated here. We are going beyond just Doppler, trying to look into other maternal cardiovascular functional parameters to see how these can be incorporated into these clinical tools. So these are very important parameters to try to think about when you're practicing. I must say it might be challenging at this moment because many settings may not have access to these tests. And something that we are looking at maybe as part of the different programs that we're trying to work on is to try to look at novel ways of delivering care to make sure that most of these tests and the care that the women deserve to get accessible to them. So we are thinking of maybe other methods like maybe AI for gestation assessment, so that in case maybe a woman comes at any time, be able to do that. We also think about actually maybe some blood tests for biomarkers that can actually give better estimates of gestational age instead of you trying to look for size of the baby. So all these are some of the ideas in the pipeline to see that care is delivered in a different way to ensure that women can be able to access the best care possible. So of course there are like some cell-free RNA transcripts that have been identified and could actually be used to estimate gestation age very accurately. But these are all still in the pipeline. But we must be thinking about novel ways of delivering care moving forward. There should be some kind of paradigm shift to what is low cost and what is accessible. Of course, as we move forward, also it's nice to reflect on the choice of standards that you use, and with a strong justification. If it's integral, is it because of how the charts were established? So you have to think about that. And what is most important for us to improve care is clinical interpretation of the results and appropriate intervention. Offering ultrasound alone doesn't improve outcomes, but appropriate interpretation of the results and providing the appropriate care is what's going to improve outcomes. And I'm happy to note that Dr. Daniel is going to give something in regards to that. And thank you for giving me a minute to say a word or two. Thank you. Yeah, Dr. Daniel, over to you. Vitas, actually, not Dr. Daniel. Yeah, thank you.
Thank you, Dr. Sam Ali. We are really appreciative for offering those cases to Eunice and Julius to use them as a demo to demonstrate this most of fetal growth restriction. Edwin, you could share. Okay, yes, it has come. Edwin. Yes.
Put full screen, Edwin. Full screen, Edwin.
We seem to be losing the presentation when it's put in full mode.
Yeah, okay, we can go the way it is.
Edwin, maybe you could leave it that way because when you put in full presentation mode, it disappears.
Sorry about that. Let me quickly share the screen again.
Yes, it has come.
Yes.
Is it a full screen at the moment or is it not?
No, it's not.
Oh,
yes,
now
that's
it
better.
is.
Yes. Thank you so much, Chair. Thank you so much, colleagues, Julius and Eunice for the wonderful educative talk. And I want also to recognize Dr. Sam, who is my boss as well. I've had an opportunity to work with him. He's a research guru, and we've learned a lot of skills from him. Doctor, you're most welcome. A lot has been said about fetal growth restriction, and I will just spell through a few things. My name's Dr. Kakama Daniel. I work in Kawempe National Pal Hospital. I've been an obstetrician for over 12 years, and I've visited a number of countries. I'll discuss this presentation in perspective of high resource setting and low resource setting. I've had an opportunity to traverse low resource settings where you may not have a scan, and what do you have to do? So I'll try to bring in those areas such that perhaps we look at it in both perspectives. Next. Next, our learning objective is basically to be able to manage the fetal growth restriction using the current evidence, and I will, like the colleagues have done, I will share the challenges that we have gone through in the management of fetal growth restriction together with the sonographers. Next, up number 9. So I will emphasize main on management fetal growth restriction and the challenges. Go ahead. Go ahead up to number 9. Go ahead. Yes. So looking at fetal growth restriction, as the colleagues have alluded, it is a discipline, or it's an area that is quite challenging. It has made the obstetricians and I think all the clinicians it has presented. I mean, it has made them to have a nightmare. There are no consensus in a number of countries, no clear guidelines to advise care. So you find that while there is no consensus to get the best approach to manage fetal growth restriction is still a challenge, a very big challenge, despite having a lot of literature around, a lot of research has been done. There are no strategies that have been proved to be effective in managing fetal growth restriction. So what do we do? How best can we manage in such a scenario? It's important to have some considerations when you're managing fetal growth restriction. Important to have considerations like in a low resource setting, just telling the mother to rest, to have bed rest and lie on the left lateral position. Studies have shown that it improves placenta perfusion. More blood is direct to placenta and tends to improve placenta perfusion. And then important to do the fetal monitoring, as colleagues have already shared, and it's also important to to track the fetal growth of the baby. You track the fetal growth either using the biometric measurements and in a low resource setting, you can track just using the maternal weight gain as they come to do antenatal, the routine antenatal. Based on early diagnosis and optimal fetal surveillance, and making timely decision to deliver. So next. So in the monitoring the mother, the primary recommended method is doing a CTG, a cardiotocography, or you do a random stress test when mother doesn't have a contraction, such that you are able to do the tracing and see how the fetal heart is behaving. This is a method that is not recommended in everybody as a routine. It's mainly for high-risk pregnancies, and the studies that have been in a low resource setting where you may not have the CTG, just doing fetal counting is just good enough. You tell the mother to rest for about 2 hours and focus her attention on counting, on doing a fetal count. If she is able to count about 10 kicks in 2 hours, then you know that that is good enough. You do it on a daily basis, especially in mothers where you suspect that their issues is a high-risk mother. Then the other aspect is doing a biophysical profile. However, as the colleagues have alluded, that biophysical profile may not be beneficial in the late onset fetal growth restriction. Studies have shown that when you do biophysical profile alone, it cannot. Biophysical profile is alone is not very accurate in predicting a fetal outcome. But it is important because it's part of monitoring of the baby. How you want to monitor how the baby is doing. The fetal well-being is very important. In situations where you are not able, you don't have a CTG, you can do biophysical profile if you have ultrasound in the resource setting. And then the other parameter to do fetal monitoring is doing the cardiovascular changes, where we look at umbilical, middle cerebral, with or without venous ductus venosus. Looking at the statistics on the poll, where about 30% of colleagues have said that they have not diagnosed, they have diagnosed fetal growth restriction, and the 30% said they have been able to do uterine artery Dopplers. Uterine artery Doppler primarily is a basic Doppler that you need to do in settings where you have ultrasound scan. Even if you are not able to do middle cerebral artery, in most cases is more reliable. Studies have shown the umbilical Doppler artery is more reliable to predict the fetal outcome compared to the middle cerebral, which is more of value in the late gestation. Next. So, looking at you are monitoring the baby, how do you decide when to deliver? Decision to deliver is guided by fetal and the maternal factors, as colleagues have already gone through. Where the fetal factors, they have talked of gestational age, you do the fetal surveillance, maternal factors, you may have a mother with comorbidities like hypertension or preeclampsia or diabetes and so many others. However, there's limited evidence to support the timing of delivery in pregnancy that have got fetal growth restriction with abnormal umbilical artery Doppler, either with absent whether with absent end diastolic volume or with reversed end diastolic volume. So in a situation where we don't have enough of this information and there is no current consensus on how to decide on delivery. Next. So what do we do? There are recommendations that have been done by the FIGO by the FIGO. FIGO is an international body of scientists that are review a number of literature and come up with recommendations. So FIGO has done some recommendations that if you have a mother who is at term, Eunice told us that if mother comes and is at term with gave us one of the scenarios as fetal growth restriction, but the Dopplers are normal. What do you do? This is a mother should deliver. However, if you have a mother who is at 37 weeks and the growth restricted, but as umbilical Doppler arteries that are becoming abnormal, this is a mother you need to monitor carefully. If the mother has got the absent or reversed end diastolic flow or as severe fetal growth restriction, these ones must be delivered immediately. So when you decide, if for example a mother comes at 34 weeks and is growth restricted and has absent end diastolic volume, this mother should consider delivery. Start planning, do a close monitoring, and you at 34 weeks and above, you don't need to do the steroids. So you just do a close monitoring, and you can be able to plan the delivery in the shortest time possible. But if a mother came and is below 34 weeks and has growth restriction and reverse end diastolic volume, that one needs to be delivered immediately. So you admit, you admit and start the steroid. As you start the steroid at the same sitting or at the same time, plan the delivery. Next slide. So the mode of delivery, literature has that the fetal growth restriction is not an indication for cesarean section. However, if you have mothers who have growth restricted and have complications of absent end diastolic flow or reverse end diastolic flow or ductus venosus changes, or you have this abnormal CTG or non-express test, or you have poor biophysical profile, these are mothers that need to be delivered immediately. Or you have preeclampsia of a severe form, or you have eclampsia, these are mothers which deliver immediately. There are those cases, it's only in those cases that you have fetal growth restriction and the vaginal delivery is not possible that you can allow do cesarean section. Next. So, as a summary of the management, I have adopted this algorithm where the colleagues have already discussed the diagnosis, and if you have a workup of this mother, you have, for example, looking at the case scenarios of Eunice, where we had in one of the case scenarios, we had a mother who came and she's one of the case scenarios. I'm just trying to try to remember. She was 36 weeks and 5 days, but the biometry showed she's 33 weeks and 5 days. Let's start from there. That you have a mother who is 33 weeks and 5 days, and you find that she has a normal Doppler. If she has a normal Doppler, this is a mother that you can allow to progress, but with close monitoring. You do close monitoring, you do by physical profile, you do CTG closely, and they allow up to 38 weeks or up to term. But if you have a mother who comes at 33 weeks and he has the end absent or has decreased, the umbilical artery Dopplers are beginning to decrease, to to show placenta insufficiency, then this is a mother that you need to closely monitor, do by physical profile, you do umbilical artery Doppler closely, do a CTG closely, so that you prepare this mother for, you start on steroid maybe for about 48 hours and prepare to deliver this mother. If you have a mother who comes at 34 weeks and he has the absent and as the absent endoscopic flow, this is a mother should prepare to deliver. You can do the delivery within 48 hours. If you have a mother who has reversed endoscopic flow, this mother should start on steroid immediately if it's 34 weeks. If it's below 34 weeks, start on steroids, but at the same time, deliver this mother. Because when they start showing the endoscopic flow, the absent endoscopic flow and the reversed endoscopic flow, these are preterminal changes that in the next 48, 72 hours, they will be able to get a stillbirth. And why do we say that if we need to do cesarean section for these mothers? It's just because that when you allow delivery, vaginal delivery, you may end up with stillbirth, or you may end up with mechanical aspiration. You may end up with birth asphyxia. It is actually documented that when you allow a mother who has an absent endoscopic flow for vaginal delivery, the odds ratio for stillbirth is about 20%. If you allow a mother who has reversed endoscopic flow for vaginal delivery, the odds ratio for stillbirth is about 40%. Next. So what are the challenges that we get? Colleagues have already discussed that we already have a lot of challenges where the obstetricians and the sonographers are not agreeing. As we said, there is no consensus. Care is individualized. A lot of studies have been done, but the guidelines still are scanty. A few guidelines are present in different countries, and guidelines following different parameters. So the challenge that we have is that much as fetal growth restriction is a common complication, but defining fetal growth restriction and making a diagnosis and come, this has generated a lot of controversy, and we still have no way of harmonizing care. We still need more research and agree on how to harmonize this care. Because UNICEF said that constitutionally you have those who are small fetuses, and they are small but they end up normal. And then you have those who are small fetuses but they're growth restricted. Getting this distinction of small fetus vis-a-vis fetal growth restriction is a challenge in many people. As you can see, that even when the sonographers do some of these things, they miss them out. It becomes a challenge to obstetrician where the mother comes with the features of growth restriction, but then the sonographer's parameters, the barometry, is not very conclusive. It also is a challenge where you have a mother who comes with small for gestational age, growth restricted, but you kind of like you are in a dilemma on agree on when you look at other clinical aspects. They don't tally with the growth restriction as per sonograph. You look at the mother's weight again has been increasing. She has no evidence of amniotic fluid, so it becomes a challenge to agree on growth restriction. When you look at the biophysical profile is good, CTG is good, so it becomes a challenge to agree on with the sonographer. So these are things that we need to make a clear consensus on how we can move forward. And it's a very big challenge when it comes to early fetal growth restriction, as the late growth restriction. Fetal growth restriction, it is quite very difficult. It poses a dilemma in management. You wonder whether to deliver a baby who is 32 weeks vis-a-vis allowing it to a little bit push such that you increase its chance of survival. So it becomes a challenge of how this can be done. Then decision to deliver is also a big problem. You have looked at the parameters. Colleagues have discussed the different parameters, the different Dopplers. Now, the Dopplers that are being discussed, sometimes in an area where you don't have the expertise, it becomes a challenge to interpret some of these results. Studies show that if you are not able to, you don't have expertise to use the middle cerebral, You don't have expertise. Use the lactus venesus. But it's important that you do an umbilical artery Doppler. Once you see a variation in umbilical artery Doppler, then suspect that there is together with as per the definition of fetal growth, estimated fetal growth less than 10th percentile. If you have the two, then you slightly increase your chance of suspicion of fetal growth restriction. So it's important that such a mother is taken as high risk, and you monitor closely this mother on either a weekly basis or bi-weekly basis. Lastly, people are asking themselves, is there room for maternal biomarkers and hemodynamics in the management of fetal growth restriction? This is still, there's little information, little studies, almost no studies have been done on trying to assess biomarkers as being relevant in the fetal growth restriction. So it's an area that is still virgin that we need to explore, whether that can add value. If we do ultrasound, we do the clinical aspect, and we can add value to the maternal biomarkers or the hemodynamics, so that we can be able to come up with the consensus of fetal growth restriction. Thank you, Chair. And next slide. There's one more slide. Yes. So what do we see as take-home message where the colleagues have discussed? Extensively. We have it's important that a combination of it's important to agree the Delphi consensus criteria, where UNIS has discussed that the estimated fetal growth restriction and the umbilical artery, if they're abnormal, then it's better. I mean, it's important that you make a diagnosis of fetal growth restriction. In the low source setting, if you just have a combination of CTG with the umbilical artery Doppler, this is just gives you sufficient information for you to be able to detect that there is fetal deterioration. But in the high resource setting, if you have the best way of comprehensive evaluating fetal growth restriction is by doing all other parameters. Do the fetal biometry, do the amniotic fluid volume, do the CTG to look at the heart rate patterns, you do the Doppler studies, both the arterial and the venous, and then do the biphysical as well. So the other take-home message is that for growth restriction with absent or reversed endostaltic flow, consider the liver irrespective of gestational age. Thank you, colleagues. Thank you for listening.
Wow. Thank you, Dr. Daniel, for that wonderful perspective. Now we really have perspective from the sonography part of it to management, what happens. Thank you, Dr. Daniel. Thank you once again. We take note there is quite a lot that we have to do, especially on the African continent. We have so many variations. Maybe these are new areas to explore in terms of collaboration, in terms of research until we reach a consensus. Because from the poll, we notice the practice for diagnosis, the definitions are quite different. The procedures of how decisions are made on timing delivery or not, all these are different. But we'll see how to reach consensus. We are so much grateful to you, Dr. Daniel, Eunice, and Julius Ojetri. Thank you very much for sharing with us your vast experience and knowledge about fetal growth restriction. I must say it is a wide topic. Not all has been exhausted. Maybe we'll have more discussions. In the meantime, let's respond to questions. I'll start from the last that came in. Suppose a mother comes in her third trimester with 2 previous scan reports done somewhere, one done at 8 weeks, 6 days, another done at 28 weeks, 1 day. This one, I must say, you consider the scan done at an earlier gestation age. So you would consider the one at 8 weeks, 6 days, because if you do dating past 14 weeks, the error margin goes higher. So you are likely to lead into more errors. So the earlier scan is much more accurate. You didn't talk about symmetrical and asymmetrical growth restriction is in their relevance. Whether Edwin, is it necessary to differentiate between symmetrical? Growth restriction is restriction. I think what matters is ensuring we have a good outcome and prevent the adverse outcomes. So irrespective of symmetrical or asymmetrical, it's just differences in the parameters. Sometimes you have all the biometry affected. Sometimes it's just the weight and abdominal circumference or a few of the biometries. But irrespective of that, growth restriction is growth restriction. Yes, it is good. Some people use the classification of symmetrical and asymmetrical because there are different causes responsible for that. Maybe we can dig more into the pathophysiology. How do you grade IUGR? Yes, you can do the grading like you saw the perspective that if you noticed from the sonographer part of it, they tried to restrict on timing delivery, but it showed the consequences, how it starts from an abnormal uterine to an abnormal umbilical, abnormal MCA, CPR, and then the ductus. And then from the obstetrician's view, it shows when to do the intervention. Of course, like I said, we'll discuss more on this. Can you please touch on on the Doppler technicalities? We'll have a topic on Doppler in obstetrics. We'll do that. Is there a protocol to follow once FGR and SGA is suspected in terms of follow-up? In other words, how frequently should patient come back? Yes, like Dr. Daniel has said, we don't have a uniform consensus, but you just have to predict what would be the outcome. For example, if you find absent or reversed end-diastolic flow in the umbilical artery, and yet the estimated fetal weight is below the third centile, would you have to ask this mother to come back in 10 weeks? Suddenly you may end up with an adverse outcome. So we are still in the process of finding consensus. How many weeks disparity should IUGR need to be to investigate? Like you've seen, maybe I would combine this with the grading. You just have to monitor and do the surveillance. Some of these models can show you the drop in velocity. For example, if we have drop in velocity by more than the 50% in about 7 days, then you should worry of that. But still, all these are areas where we need consensus. Please, can we have some question? Oh, okay. Okay, let me see more of the questions. Will the recording be available? Yes, it will be. I think for now, those are some of the questions. Most of it people are appreciating. Thank you. So if the mother is sure of LMP and did not do the dating scan, can't we consider LMP? Yes, we know LMP should be the ideal, but we found circumstances. What they may tell you of the LMP, just ask them to go to the next room and they'll tell that sonographer or obstetrician in that other room a different date. Or someone will say, maybe it happened between 25th and 28th. Sometimes they are not very sure, but if they're sure, then better to go with the LMP other than going for a wrongly detected pregnancy. Any comments on diagnosis of selections of criteria? Of course, different forms. What has been demonstrated here may be more so of the classical cases, but fortunately there was an atypical case which was exhibited here. But most important is understand the principles that underlie the definitions of growth restrictions and how it can be diagnosed. Edwin, you could add maybe a few comments. You are an expert and have had vast experience in this field.
Sorry, I didn't catch that, Vitus. Go ahead and repeat your question for me, please.
I was saying maybe if you could wait about fetal growth restriction. There's different consensus. There's lack of course. Everyone does it their way. So like you can see most of the questions they're asking, the grading, for example, if the dating all is wrong, to use LNMP, maybe if you could give some light a bit about that.
LMP has its own challenges. Even when the mother is sure, it does not guarantee that the gestational age is accurate. The mother might be sure, but the gestational age might be quite different from what you expect. I happen to work in a setting where about more than 95% of the women will come in the first trimester for their dating scans. So only a small percentage, about less than 5%, will come later than that. And even with these who come at the first trimester for dating scans, when you go through their clinical notes and you compare the gestational age using the ultrasound CRL, and you compare that to the LMP, you'll notice that there are some cases where there's a huge and quite significant difference in gestational age. Some of it even surprising the mothers who actually will tell you and confirm that the LMP was accurate. So whereas we can use it, in some cases it will not be as reliable as you want it to be. The other question I had was about maybe the symmetrical and asymmetrical growth restriction. Where it becomes important is because the symmetrical one you can easily confuse for a normal small baby. So you have to be careful about that. And that's where these other parameters like the Dopplers come in to help you. Otherwise, if you measure the head, tummy, and legs, and they all say 22 weeks, when this baby is actually 28 weeks, then surely there would be a problem. I don't know what else you talked about, Vitus.
Thank you. Dr. Daniel, someone has a question. How should a mother frequently come back if there is any suspected growth restriction? Is there any specific protocol to this?
Thank you so much, Chair. We earlier on say that there are no guidelines and the care is individualized. How frequent they should come will depend on the severity of the fetal Dopplers. If you are dealing with a mother where you're able to do the fetal Dopplers, for example, if a mother comes and he has the umbilical artery Dopplers are beginning to deteriorate. When they begin to deteriorate, that's a mother that you keenly try to follow up. They say, let's do Dopplers every after 1 week to study, see whether it's deteriorating or not. Studies have shown that if the umbilical artery Dopplers start deteriorating, by the time she reaches ductus fedosus changes, it may take about by the time she reaches the absent diastolic flow, it may take about 28 days. By the time she reaches the reverse end diastolic flow, it may take about 13 days. And when she gets into the ductus venosus deterioration, she has only 4 days for that baby to live. So that's what you individualize care depending on how you see the mother's Doppler studies. You also individualize care depending on how you see the biophysical profile. Biophysical profile, it is a supplement of the Doppler studies. It guides you on to do a timely intervention. If you find that Dopplers may be good, but the biophysical profile is poor, then you deliver. So that's how you may not specify that every after 1 week per mother. It depends on the Dopplers. You do 1 week. There are those we do 2 days. There are those we do 4 days, depending on the severity of her Doppler changes. 2, I wanted to put a comment on symmetrical versus asymmetrical. In a clinical sense, the symmetrical versus asymmetrical has been a challenge, and I think this is based on the studies that some schools of thought, like the Society of Fetal Maternal Medicine, believes more in the classification of early versus late fetal growth restriction based on some studies that were done on about like 500 mothers, 600 mothers, where they found that the prenatal outcome below 32 weeks was significant and it was distinct from the prenatal outcome after 32 weeks due to physiological changes that occur below 32 weeks and after 32 weeks, as opposed to the prenatal outcome that they would see in the asymmetrical versus symmetrical, where they saw similarities and it did not have any differences, significant differences in the outcome on the likely complications that may occur. And then the issues of LMP, the last nomination period, whether we can base on it. Sometimes it poses a dilemma. You have a mother who comes and she has she clearly states LMP, but you may not be sure Then you have a ultrasound scan of first time, which is done in second or third trimester. It doesn't give a clear picture. So it leaves a dilemma to the clinician to decide what is best to follow. We have those challenges. You find that the mother, time she comes, she has DC by physical profile that is going down due to placenta insufficiency. You want to find out, is it growth restriction or it is something else? So it poses a dilemma. But however, in low resource setting, if a mother is very sure of LMP, then we rely on it. It is in those settings where you think that you have ultrasound scan, then you supplement the LMP with ultrasound scan findings. Thank you, Chair.
Thank you very much, Dr. Daniel. Thank you, Eunice Namwase, and thank you, Ojetre Julius, for the extensive and wonderful discussions today. We are so much grateful to Ultrasound Africa for giving us this platform. All cannot be exhausted. The links to the YouTube, LinkedIn, WhatsApp, and the social media of Ultrasound Africa have been shared in the chat box. You can follow them for more. There will be more discussions. It's not possible to exhaust it all of here. And thankfully, we have the experts. Dr. Samuel is here, Dr. Daniel is here, and the rest of the expert sonographers. Edwin is a specialist consultant fetal sonographer in London, so you can reach out to him. Tugume, our founding CEO, is also with us here. He's also an expert in fetal medicine, ultrasound. I want to thank you all, but in a special way, we recognize the presence of the members of Ultrasound Africa, our founding CEO, Mr. Tugume Benjamin, the finance director, Sayed Hamdoun, who's also an expert in obstetric ultrasound, and Amina Nakato, who's also an expert in one of the topics that we are going to discuss next. So as we invite in our CEO to close up the session, our next webinar will be on the 28th of July, which is the month starting tomorrow. And this will be about another topic where we don't have consensus, another topic where there is very little done about the IOTA and the adnex models that could help in classification of those adnexal masses into, is it either benign or malignant? And then what next thereafter? So Edwin, if you have anything else, maybe Tugume, you could come in and close this session. I thank you all on behalf of the hosting team, and have a good afternoon and a good evening to the rest.
Thank you, Vitus.
CEO to close the session. Okay, let me, okay. Mr. Tugume, I have unmuted your microphone.
Hello, everyone. Thanks for always coming for these webinars and coming together so we can all learn. We are so grateful that you save this time to come and also, save these mothers, and also a way of improving practice. And we hope to see you again on the 28th of July. Special thanks to the presenters tonight, and also to the presenter's mentor, Dr. Ali Sam. Thanks for being part of this talk. Thanks very much. Bye-bye.
See you on the 28th of July. Viva Africa and the rest of the world. Go safe.